Hi, everyone. I'm Alex Doman, and I'm pleased to welcome you to today's webinar, Understanding and Treating Auditory Processing Disorders, a Multi-System Approach. We're so pleased to have you all here. So just to cover a little housekeeping before we get going, I want to thank you all for the questions you submitted when you registered. Boy, do we have a lot of great questions coming in for Dr. J today. You can submit additional questions during the webinar via the chat. We've structured the webinar to cover as much of the information as you are curious about when you submitted questions. And after the end of our conversation, we'll have an additional 15-minute Q&A where we'll cover any open questions that we have. If we don't cover what you need, our team will help you directly, and we'll share how you can contact them at the end of today's webinar. We really appreciate your understanding that we cannot answer specific client questions about individual APDs or treatment in today's webinar, but again, our team can help you with that. So again, today's webinar is Understanding and Treating Auditory Processing Disorders, a multi-system approach. We're going to explore the complexities of auditory processing disorders, how they relate to sensory integration, emotional regulation, and the vagus nerve. We'll dive into evidence-based strategies, including the listening program, and how they support individuals with APDs, auditory hypersensitivities, and some specific discussion on how they relate with autism spectrum disorders. This session is intended for clinicians, therapists, educators, and other professionals serving individuals with APDs. And our goal today is to really provide you with some practical insights that you can apply in your practice today and in the future. So please, if you can, stay for the entire session, including the Q&A at the end, and for important announcements that you're not going to want to miss. So today's guest joining me is a colleague that I've enjoyed a couple of decades of a great relationship with. Dr. Lucker is an internationally recognized expert in the areas of auditory processing and language processing and disorders in these areas. He's well published, having completed multiple research studies on auditory processing disorder, including effects of treatments such as the listening program. His research has shown significant reductions in negative emotional reactions when listening and greatly improved listening and auditory processing skills in people, including those with ASDs and those that have completed listening therapies such as the listening program. Dr. Lucker is Professor Emeritus from Howard University in Washington, D.C., where he taught for 21 years. He's an invited professor at North Carolina Central University, where he's presently teaching, and at Xavier University of Louisiana, where he has taught in prior semesters. His private practice specializes in evaluating, diagnosing, and identifying appropriate and needed interventions, treatments, and accommodations for people with auditory and language processing disorders. Dr. J, welcome.
Thank you for having me. I'm looking forward to this.
Yeah, as am I. And we've got a lot to cover, so I would like just to jump right in if that's okay with you.
That's fine with me.
Okay, let's do it. Dr. J, can you've been in this field many, many years, as we were discussing earlier, and I would love for you to kind of share your current perspective on auditory processing disorders, how you define APDs, and why it's important to consider a multi-system approach in understanding and treating them.
Surely. So actually, I have published on this, so those attending who will look up my name, you can look up, you may be able to come across some of my publications that talk about this multi-system approach, or it's auditory processing disorders has been around or has been identified, for those of you who aren't familiar with it, since the 1950s. So can you imagine that 25 years from now, it'll be 100 years ago? Okay, it's a long time ago. The thing is that when it was identified, and the way our profession, these are audiologists, hearing specialists, and speech language pathologists who may be members of our professional association, ASHA, the American Speech Language Hearing Association, or the American Academy of Audiology, or both, like myself, okay, have identified it as mostly the way audiologists focus on it, that auditory processing is something wrong with the central auditory nervous system. For those of you not familiar, this is my ear. Does everyone see it? Okay. It is there for a very specific purpose. It holds my glasses. No, I'm joking. I'm joking. Okay. The thing is that our ears are here to pick up sound. The sound then travels through the what we call the brainstem and eventually gets to the brain, the cortex. The traditional way of looking at auditory processing has been, and even to this day, is still focused within our profession, is it is a problem with the transmission of sound from the ear to the brain, to the auditory center of the brain. For those who are familiar with it, it's called Heschel's gyrus. Now comes the thing, though. Sorry, but all of us just had an auditory task. How many of you are aware of that? I was. Okay. Okay. That basically what our auditory system in and of itself does is it transmits the sound. Now, how many of you would agree if you travel from your house to work and you have a map, you take certain streets? Listen carefully to the question. Do the streets get you to work? You see, cognitively, you might say yes. The answer is no. Your car gets you to work. Your motorcycle gets you to work. If you walk to work, your feet get you to work, right? We take different streets to get there. So there's multiple things going on. When we hear something, the ultimate goal of what we hear is to make sense out of that. So when I say hello, you make sense out of it. How do you make sense? One, you hear it. Two, what we do is realize of all the things we hear, what's the most important pieces. Now, when I said hello, it's only one. It's only one hook. It's only one word. But if I said, hey, it's you, hello, how many of you would agree? I still only said hello. But I said, hey, it's you, hello, which is 5 words. But we processed it to get meaning out of it, to know that it said hello. One, linguistically, the language. So there's another system involved. Two, cognitively, what does that mean? And three, we integrate different senses. For example, if I were to say to you, hey, it's good to see you, hello, would you agree my smiling face, my waving hand help you to interpret that I'm saying, the interpretation I would say is greetings, right? So we use multiple systems, and a lot of these systems may not function well. Number one. Number two is the connection between them may not work properly. And so if a system isn't working well, I'll use the language system, okay? For those of you who do not speak foreign languages, I'll use Spanish as the example. If I say, hey, hola, ¿cómo está? How many of you agree? I just said the same thing that I said before in English, right? But you have to know the language of it to know exactly the words. And if you took a foreign language like I did, you learned a lot of the words, you learned the language, and probably very shortly you start learning how to put it together. And then someone said, hey, how did you know how to speak to that person who speaks Spanish as the example? You know what the answer is? My teacher taught me in school. Yeah, but what'd you say to them? I don't know. It was just the thing to say. So after a while, we just kind of figure out emotionally what's the thing to say. If someone says, hola, ¿cómo está? You say, muy bien, ¿y usted? And then someone says to you, what do you mean by that? I'm making believe, right? I don't know. But I know that when our teacher in class used to say, hello to the class, that we were supposed to say hello to the teacher, and then the teacher would respond, muy bien, ¿y usted? So look at all the systems that are involved. It's not just the auditory system.
Well, to that point, Dr. J, let's talk about these other systems, the sensory system, the limbic system. We know it's just not the classical auditory pathway. I'd love for you to elaborate on the interaction of these systems and how they can contribute to, efficient processing or a disordered processing ability.
Surely, surely. Okay, so I'll go back to the hey, hello, how are you? Listen carefully. Hey, hello, how are you? Got that? Now listen to this. Hey, hello, how are you? I hope we'd all agree that linguistically I used exactly the same words, but did I say the same thing? Thank you. I see a lot of heads going, no, you're right. The rhythm of the way I said it, which really is very musical if you think about it, and the auditory is very musical. We have to remember that, okay? Was very important. And here's the joke that I make when I teach, okay? Someone says to you, this is how much 1 plus 1 is. 1 plus 1 equals 2. And you say, really? Now, would you agree by hearing that, your auditory system heard the really, but heard that rhythm going up. Your language system heard really means I agree, okay, or something like that. But your cognitive system and the sensory system, sensory feels that rhythm. And I'm asking a question, meaning I didn't know that 1 plus 1 equals 2. By the way, for those of you who don't know, 1 plus 1 equals 11. No, I'm joking. I'm joking. I'm joking. I'm joking. Okay. The other thing is, what if I said, hello, and you say, really? How many of you would say, I didn't mean the same thing again? Or if I said, oh, really? You know, the rhythm changes everything. And that rhythm has two major components in our brain. One is that sensory, the auditory and the sensory system, and that harmony of the musicalness of it, but also the emotionality of it. And one thing that a lot of us don't learn if we are audiologists or even as speech language pathologists, we learn in our undergraduate work, we have to take coursework in the field called anatomy physiology, and we do the auditory system. We learn about the classical auditory pathway, the ear, the brainstem, getting up to the brain. But there is also a non-classical, as Alex brought up, a non-classical system that goes from the upper brain stem directly into the limbic system. And if those of you aren't familiar with it, the limbic system houses our emotional system. So that the auditory system is directly connected with emotionality. Now, what's interesting, if you read the research, the visual system is not. We see something, we cognitively interpret it, then it goes into emotionality. We feel something, we physically feel it and interpret it, then it goes into the cognitive system, and then it goes into emotionality. So that when we taste something, when we smell something, it always goes into that cognitive. We have to interpret what it is in some way. And then, and we may cognitively interpret it without being even aware of it. It's part of our sensory factor. Then it goes into the emotionality. But with the auditory system, it goes from the auditory system directly into the emotional system, and then it may go into the cognitive system. But if that emotionality is very negative, it could be a very distorted cognitive thing. I'll give you the example. It's called hypersensitivity, oversensitivity. Many children, especially people, and I shouldn't say children, it's people, because it could be even adults or older people with autism spectrum disorder, ASD, very often react to certain sounds in a very negative way. You know, I hear a siren coming down the street. It's annoying. I don't like it. I'm waiting for it to leave. It's gone. Yeah. Right? Now I'm a person with autism. there's a siren and it's, let's say, 3 or 4 blocks away. Oh my God. Oh no. Oh no. Oh no. No, 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 no. Is it gone yet? Is it gone yet? Is it gone? And we have to calm the emotional system, the auditory system, and it interferes because what the systems do is they're not stupid, they're smart. They shut down. And if they shut down, the sound doesn't bother me as much. But if the sound doesn't bother me as much, I turned off listening. And if I turn off listening and you're talking to me, this is what I hear. You did hear something, everyone, right? I hope, okay? But you couldn't make it out because my system shut down. That's what happens, especially with a lot of kids with ASD. They shut down. But there's also a lot of children who don't have ASD, but they may have this oversensitivity. Fancy word, hyperacusis. Hyper, right? Over, acusis, auditory. And the thing is that they shut down. Now, we'll talk about this a little later, but there's treatment for it. And actually, my first introduction to this company called Advanced Brain Technologies, if you're familiar with Alex, and the company is that was their listening program or listening therapy, which is what it is, that really helps reduce the hypersensitivity, the hyperacusis. I hope you heard me or watched me and saw how I was coming down, right? Because I did the listening therapy. So the noise still bothers me. You know what? It bothers all of us, but it's no longer bothering me to the degree that I shut down or that I become emotionally upset. And that's important. So we now have those. The other thing is, one of the things I've had a lot of, I apologize to use the word arguments with audiologists in my field, is that the visual system is very important in auditory processing as well. If I say to you, go to the door, but watch me, okay? Go to the door. Would you go to the door on your right or your left? Would you agree it's the direction in which I'm pointing? But I didn't say that. You use your visual system and put it together to follow through. But what if the visual auditory system is not working together very well? The other thing that's important is we have how many ears? 2. And how many sounds do you hear? Typically, or words? 1. The answer is no, you hear 2. You hear a word in the right ear and at the same time a word in the left ear, but the brain realizes they're the same word, so it's one word. There's an integration of the two sides of the brain. That very often doesn't work. As a matter of fact, one of the most common, other than the hypersensitivity, one of the most common problems I see with children with ASD, as well as with other children, adolescents, and even adults with auditory processing problems, is a problem called auditory integration. The inability to integrate, to work together in a harmonious way. My analogy, everyone ready? You're going to go to a concert, okay? There's going to be 10 people who are sopranos. There are going to be 10 people who are altos. They're singers. There are 10 people who are tenors, 10 people who are baritones and bass. Okay, so that's basically 40 people. If my numbers were correct, right? Okay, but whatever it is, it's more than 10 people. How many sounds do you hear? How many melodies do you hear? Does everyone agree? 1. If we're all singing properly and there's integrative harmony, we hear one beautiful sound. But actually, the tenor is not singing the exact same note as the alto, who's not singing the exact same note as the bass and the baritone, who's not singing the exact same note as the soprano. Same with instruments. When you think of it with instruments, they're not playing the exact same note, because a trumpet sounds very different than a violin, which sounds very different than a piano. Does everyone agree? But if they're playing together in a harmonious, integrative way, you don't hear the difference. You hear the song, the music, the last note of the song. Ah, boom.
Dr. J, going back to hypersensitivity, hyperacusis, there are labels that are interchanged. We hear the term misophonia,
Mhm.
hyperacusis, hypersensitivity to sound. There's a large and growing community of adolescents and adults that identify as having misophonia specifically. From your perspective, are there differences? If so, what are they? Or are these the same label applied to the same phenomenon?
Okay. The main difference that I see within my approach and my way is that auditory hypersensitivity, which we call hyperacusis, is oversensitivity to sound. Everyone hear that? And I didn't tell you which kind of sound, did I? So it's usually sound, and it's usually at a certain volume level. Okay, if you're not familiar with it, we measure volume in decibels called dB. Okay, and it's a very auditory based problem. Okay, then there's a hypersensitivity to specific sounds as opposed to the loudness of the sound itself. And the fancy word for that is misophonia. It is, I cannot tolerate sounds A, B, and C. I am misophonia. My twin, okay, that's how we do it, right? Cannot tolerate sound no matter what it is. That's, let's say, 80 decibels. Just so you know, normal conversational speech is somewhere around 50, 55 decibels. Okay, loud speech, sorry, I didn't mean to yell, okay, can be as much as, let's say, 65 to 70 dB. 80 is even higher, okay? And so the thing, you just imagine someone yelling in your ear. Okay, there's a big difference. Does everyone agree? And the thing is that misophonia might be, I don't care, I'm sorry, auditory hyperacusis without the misophonia might be, I don't care what the sound is. If it hits this volume level, forget it. I can't take it. As opposed to someone saying that, can I share a real story? We have a good friend who happens to actually be an audiologist. And the thing is that we got together the very first time with family. So I went with my wife, she went with her husband. When we go into the restaurant, she says, can you do me a favor? Get a long table, not a round table. Wants a long table. She would sit at the right end or whatever end it is, and her husband sat at the left end. And we said, without trying to make okay, because I mean, I don't know if you go out to eat, but typically you want to sit with I want to sit next to my wife. Okay. So we just set it up that it would be man on one side, the man on, the man on one side, the women on another side. But she's all the way at the right end. Her husband's at the left end. And then I was sitting at one end. It was, like a square rectangular table on one side, and my wife was sitting opposite me. And then afterwards, I asked her, why do you sit so far away from your husband? And she says, I can't tolerate him eating. When he chews, when he bites things and all, the sound drives me crazy. And then I asked her, just out of curiosity, have you always had this? She says, oh, yeah. Ever since I've been a child, I couldn't eat in the cafeteria in school because other people, as opposed to, or if they're eating soup, you know the sounds that I'm talking about, right? She has misophonia because if you were just to clap your hand very loud right next to her ear, she would jump like this, like everyone else, but it would be gone. As opposed to someone with hyperacusis, you do this, and the first thing they may do is run out of the room. They don't want to see you. They don't want to be with you at all. The good news is that the listening therapies, as we call them, such as the listening program, helps both because it reduces the limbic system reaction to the sound. So the sound is no longer, I'll just use the word identified. Does everyone understand what I mean by that? Is no longer identified as being uncomfortable or annoying. Okay. And what I've seen, even with people with hyperacusis, is that you can start making very loud sounds once they've gone through a listening therapy. Okay. And they're no longer bothered by it other than being bothered by the way anyone would be. Would you please quiet down? Notice how I'm saying it, as opposed to see the difference? I hope you don't mind.
I think that's incredibly helpful. And maybe stepping back just to some basics for the practitioners with us, and as we think about auditory processing and the symptoms that are observed, so often kids with auditory processing issues I have witnessed are misdiagnosed or not diagnosed. They may be seen as having ADHD. Maybe there's some comorbidity, but what are observations that our practitioners can make that would lead them to make a referral for the appropriate assessments for diagnosing APDs? And what would be the steps that they may take to, say, see yourself, Dr. J, or a colleague? What should they be looking for?
Okay, well, I'm going to make a little joke here. So you want me to talk about ADD, right? Does everyone understand that Alex said APD, but I processed it as ADD because I have a phonological processing problem. I mishear the P as a D. Okay, that's one very common thing. A person responding to something, okay, because they mishear the sounds in words. Typically, you'll also see problems with reading because that has a lot to do with how you learn to read. And spelling, that's a big one too. Writing, therefore, spelling too. That's one possible, and that's phonological, the sounds. The other is mishearing the word, right? Or misinterpreting the word. So, when someone says ABC and you say, I don't see any A's or B's around at all. Did you notice that I took the word C and misinterpreted it linguistically from the letter, which is what I meant, to SEE, or, oh, I don't like going on the water with a boat. Would you agree that's SEA? Okay, so a lot has to do with putting those pieces together to combine, to understand it, and for the person to hear it. From the hypersensitivity point of view, it's usually observational. And very often, if you meet someone, let's say you're doing evaluation or you're doing counseling or therapy with someone, okay, it will say children, since you mentioned children, ask the parents about how does the child react to sounds? How is the child in listening? Okay. The other thing is, remember what I said earlier? System shutdown. Okay. What happens when your systems shut down? You stop attending. But listen carefully to what I'm saying. You stop attending as opposed to you stop yourself from attending. You got it? In other words, I didn't stop myself from attending, but because of, let's say, the hypersensitivity to the loud sounds and all, my system shut down. Or the frustration of not understanding the teacher in class in a lecture, or someone giving me directions, or someone giving me instructions, or just even asking a question can cause my system to shut down. Most common response is, what'd you say? So that's a very common response that you see. And the thing is, what we tend to do when someone says, what'd you say? We repeat ourselves. But a nicer way to do that, to check it out, to see was the person really paying attention, or was it an auditory processing issue? Is that, well, maybe I wasn't clear. What did you think I said? And a person who has an attention problem may actually say to you, oh, you told me to go, that my hands were dirty, go wash them. Whereas a person with an auditory processing problem says, I don't know. What'd you say? Does everyone understand? Because they didn't get it, so the system is just lost. Okay. Another way also is, and I think that's one of the things you were bringing out, Alex, is that a lot of, well, we're still with children, but it could still be adolescents, adults as well, who have auditory processing problems because of the system shutdown, are given a four-letter diagnosis. Everyone knows what that common diagnosis is, ADHD. Okay. And the thing is that it may not be ADHD. There is an alternative, though. I always explain this to parents. If we were to say, what's your diagnosis? Oh, my son has ADHD. I said, okay, if we were to give that diagnosis, then on a scale of 0, or let's say 1 to 10, would you agree maybe it has to be an 8 or higher before the person says you have ADHD? But could it be that the person has ADHD of 3 and auditory processing of 5? But the one thing that they're doing is only looking at the attention and not looking at other factors of listening, okay, okay, of responding appropriately or inappropriately. Very often, if a person responds, and let's say they respond incorrectly, take a second before reacting to them or whatever, or continuing the conversation. What in what they responded, whether what they did or what they said, could be correct if I can think of them mishearing what was said, as opposed to them interpreting it because they didn't get it all. Okay, auditory processing is mishearing. Not getting it all is because I was this, and then all of a sudden I opened up and then went like this. Or as my system, shut down, or my brain shut down because of ADHD. So yeah, a lot of people have both the combination of ADHD with auditory processing. APD is what we call auditory processing disorders. And the thing is, all they get is the ADHD diagnosis, and immediately what happens is, here's the medication. So here's the way I look at medication. Is everyone ready? I'm going to make an assumption. None of you have ever been to Mars. Am I correct? Okay, good. Okay, that's great. What if I said, I'm going to hold a gun to your head? You must describe what life on Mars is like. Well, I did see the movie The Martian. Life on Mars is you grow potatoes, if you know the movie. Okay. Okay. No, it's not. Okay. The thing is, you'd be scared because I'm holding the gun to your head, right? Okay. Well, what if I said, I know you're anxious and you can't respond. Take this medicine. It'll calm you down. Make believe it truly does. It is the most miraculous thing. You take it, and 2 seconds later, you're totally calm. You don't care that I have a gun into your head. Now, would you tell me all about what life is like on Mars? I hope you understand what I'm saying. You can't if you've not, if you've never been there, right? So the thing is, if the person has an attention problem and they can't pay attention, we have to train them to pay attention. The person has an auditory processing problem and they can't get it, so they don't pay attention, right? Or their system can't because they can't get it. Medication is not going to teach them the skills,
Right.
right? The only way you can know what life is like on Mars is, let's go to Mars. We'll settle there for a year. Then you'll come back to Earth and you'll tell everyone what it was like to live on Mars for a year. And guess what? Notice I didn't say taking medication.
Dr. J, we haven't talked a lot about cause, right? And what do you see, and has your experience changed on, what's contributing developmentally, environmentally to APDs, and are you seeing anything that's changed that to me appears it's not just more awareness, but we're seeing an increasing number of individuals that have auditory processing issues. I'd just love your perspective on this today.
Okay. Well, one perspective, it's a couple of things, but one perspective is, one of the things that is very commonly used now is that people who have, will go back to the loudness tolerance. When a person has loudness tolerance, how many of you are familiar with what the very first thing that people do is they use noise reduction earphones or earplugs? What they're doing is they're externally training their system, when there's a loud or annoying sound, not to do anything about it, because your headphones will do it for you, or the earplugs will do it for you. And therefore, okay, so here's the best example. Again, using that 1 to 10 scale. Okay. let's make believe that as soon as that annoyance of sound hits the level of 8, it becomes a real serious problem, whether it's hyperacusis or whether it's misophonia, right? So every time I'm going to listen, I'm going to put my earphones on, okay? I started with an annoyance of sound at 8, okay? Listen carefully. But by using the earphones, how many of you would agree? It's not only going to not go away, but eventually it's going to get up to 12. That's on a scale of 1 to 10. You understand what I'm saying? It gets worse. Because what we're doing is the following. I use the example of when I talk to people and talking with you, break your leg. You broke your leg. I'm going to give you a crutch. How many of you would agree a crutch or crutches will help you walk with a broken leg? How many of you would agree, but I'm not going to use the crutch for the rest of my life? But when you give the child, especially the earphones or the earplugs, what's the child's expectation? I can use it all the time. And they don't learn. So that although sound was bothering them at a level, let's say, of 3, but we counted it as 8, it's going to get worse. Second, you have to listen more carefully, right? So do we listen more carefully? Yeah. Yeah. I put my headphones on or I put my music in and people are talking to me and I can ignore them and it's accepted. What do we
So
do?
in
Yeah.
truth, the accommodation being made is contributing to a worsening
Yes.
of the situation. And
Yeah.
that's, I
Oh,
think, people go toward accommodations. It's always difficult to see children on the spectrum in public in earmuffs, to see people constantly working with auditory input coming through headphones. And as we know, if
mhm.
the amplitude is too loud, then we have a second contributing factor of noise-induced hearing loss with too much time listening through personal listening devices. So it's another factor. Um,
Mhm.
I want to shift our conversation a little bit. I was having a conversation. I believe you know Dr. Leon Flores. He's a otoneurologist on our team in Monterrey, Mexico. And a few weeks ago, he and I were having a talk about a change in focus in his practice on dementia, Alzheimer's prevention, with recent research showing the number one symptom that we see that could be a precursor or a sign or susceptibility to dementia is hearing loss. And I'm interested in maybe your perspective on that if you're familiar with the developments here, but just the importance for those of us that are aging. We are all aging, but as we start reaching certain ages, to be more aware of protecting our hearing and more proactive in contributing to improved listening to maintain functional hearing so that we may have a longer, healthy cognitive life. Any thoughts on that?
Yes, and since my focus is auditory processing, I'll talk a little about that. Okay, so I'm going to be your father, okay, and I am going to hit the age of 50, but because of my work environment, or maybe even a familial factor, at the age of 50, I start losing my hearing. Okay, so this is the way my hearing was, right? And now my hearing is, by the way, losing it goes down, right? Is getting worse. Okay. So everyone blames the fact that, oh, he's busy, so that's why he's not paying attention. So I also I stop paying attention because I can't get what people are saying. So I start ignoring people. Okay. And then I'm now 55. I'm used to that. And people are used to me ignoring them. We go to parties, everyone's talking, and I'm just sitting there, drinking my beer or whatever. Okay. Now I've hit the age of 60 and I start noticing that I'm having some trouble hearing, but I blame it on you. You're not speaking so I can understand you. Even though you're speaking, let's say we use dB. Every doubling of dB is 10 dB. So you're speaking 10 dB louder than you would speak to anyone else, doubling your volume. But you're not speaking loud enough. Look at me, talk to me. Come on, speak so I can hear you. And then why bother even listening? So you stop listening. Well, when you stop listening, you stop thinking. When you stop thinking, unfortunately, one thing that can start hitting is the natural introduction of dementia is made worse. Then I hit the age of, oh, ripe old age. Just had my birthday, by the way, and I'm 70 years old, son Alex. Thank you for the birthday party. And the gift that Alex gives me are my hearing aids. Okay, thank you for them. Okay, and all of a sudden I put them in. Now remember, I wasn't hearing well since the age of 50. 20 years have gone by and everything sounded like this. I hope you can still hear me. Okay, a little bit, right? And all of a sudden, I put my hearing aids on, and this voice sound all of a sudden is very comparatively to what it was. Okay, how many of you would do the following? Continue to wear the hearing aids. I hope the answer is even Alex has said it. That's what I'm saying. They don't. So I make a joke. Okay, we have different kinds of hearing aids. One type is called behind the ear. Another type is called in the ear. Okay. Another kind is in the ear canal. It's very small. They go all the way in. We abbreviate them BTE behind the ear, ITE in the ear, ITC in the canal. And then there's the ITD hearing aid. Can anyone guess what that is? ITD. What could that be? Are you ready? In the drawer. You get your hearing aids, you put them in the drawer, and you just leave them there. And that's what
That's my
happened.
father, incidentally,
Oh,
in truth, Dr. J.
yeah.
In the drawer.
And then what people do is either they just put up with the fact that you're not listening or paying attention to everything. But then what happens? You stop thinking. Remember, auditory processing is still cognitive. And so whereas we'll make believe this is the average age, right? Then you start developing, emotional problems as well, dementia and all of those aging things. Okay. But because of where I am, because I'm not listening and I've gone 20 years that way, it's like this. It just, I was trying to make the picture off the roof. Did everyone know that? Right? Yeah. And yeah, it's a big problem. The other thing that bothers me too, for all of you who work with people who do get hearing aids, is the one thing audiologists say, here's the hearing aids. Here's how you put them in. Here's how you chart. This is the old way. Here's how you change the battery. Here's the new way. Here's how you recharge them, because hearing aids now are rechargeable. Okay, this is what you do. Blah, 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 blah. Okay, guess what the person never says? Okay, now go for some listening training to relearn how to process what you're hearing. Okay, instead, what the person says, were you paying by cash or check? Or is that a credit card? Excuse me, you know what I'm saying, right? We don't do therapy. We don't teach. You have to relearn how to listen. The average person getting hearing aids, and I work with people who are, let's say, in their 20s or 30s who have lost their hearing, or even a few older, but around that age level, and they're in school and they're very concerned. I recommend start doing some listening therapy, because it will make a big change. What you're doing is you're exercising the auditory system to process what it's taking in, and do some of that listening training with with your hearing aids on.
So, Dr. J, a lot of topics I hadn't planned on speaking, but I've been inspired, topically to delve into based on some, recent conversations. And we haven't talked a lot about treatment. Many of our guests are trained listening program providers. They're very familiar with TLP and when and how to use it, but as many are not. There are other practitioners that may not be trained in any listening therapy or the listening program. Just your experience, to my knowledge, Dr. J, you are the most published researcher in the field of listening therapy. I am not aware of anyone that has as many publications in this subject area as you and deep clinical experience. So I just a few minutes before we transition to Q&A, just kind of your perspectives on when and why you would use the listening program as a recommendation to your clients, and maybe as a guideline to those practitioners here that aren't offering the listening program.
Okay, the first thing is I'm going to use the most common reason. If there's the oversensitivity to sound and noises and loudness, the hyperacusis, as well as the misophonia, okay, that auditory to limbic system connection, very critical, very important. What the listening system does is two things, and I'll just use a generic way of describing it. Number one, and I believe this first is what's first going on, it reduces negative reactions, or the best way I could say, negative emotionality. It really calms the system. I don't know how many of you are familiar with something called the polyvagal theory. There's something called the vagus nerve. The vagus nerve goes from the limbic system, are you ready for this? To the heart, to the throat, to the stomach, to a lot of other parts of the body. There's a tremendous, tremendous number of things that it connects to. And the research that I've done, as well as, just what people have said, is how much after doing the listening therapy, even before it's completed, they already say, I feel so much calmer. My stomach doesn't bother me as much, when they're listening or whatever. Sounds aren't bothering me as much. And so the thing is, it really does a tremendous improvement to reduce that. The second thing it does, it then opens the system, right? Remember what I said? If it's very noisy, very loud, how many of you would agree? You just stop listening. You basically, right? Okay. But we do it also mentally, not just, physically. And the thing is, what if I can now listen and it doesn't bother me as much? Oh, I can hear again, right? So it opens up the auditory system. And therefore, if I need therapies that have listening therapy, talking therapy, whatever it is, I'm ready to do it now. Second most common use that I find that's very successful is a lot of people, especially children, we recommend listening therapies for the different types, notice the plurality, of auditory processing problems, not just the sensitivity, but that integration, okay? Also the phonological, the sounds, which help with the reading, spelling, also distinguishing the words that we hear, and things like that. They need therapy. And what happens is sometimes I've had therapists who will say, I'm just going to pick Alex's name. Alex is a client and he's going for therapy, and my client, Alex Doman, is not making progress. I've been trying this and that. Then all of a sudden I say, try a listening therapy. Maybe the listening system has closed down because of the frustrations. And all of a sudden, this is what you start seeing. It opens up. And all of a sudden, they may do now it's not redo the therapy, but do some of the activities. And all of a sudden, the brain is now making sense out of it. And all of a sudden, you find the person is no longer just reading words, but reading brand new words, decoding them, hearing things from a speaker who, let's say, has an accent, foreign dialect or whatever, and now understanding that person, listening when there's noise around and filtering it out. So it's a great, what I call base to start when you do listening therapies. Yeah.
Very, very helpful, and I'm glad to see we're aligned. And the great thing with our relationship is Dr. J and I haven't always been aligned on all subjects. We've had healthy debate and conversation and learning and growing together in our perspective and experience. And that's one thing I've really appreciated, Dr. J, is your openness in that regard. And kind of tying to that openness, before we transition to Q&A, what do you see like the future? What do you see emerging in research, in our field, and kind of the future of listening therapies, and what might be on the horizon that's got you excited?
Okay. One thing is technology. And so that's a big improvement. And technology for two things. One, for evaluations, in other words, for research. So that's really changing a lot. the technology for developing, within the same products, new and better systems, new and better things that we can do. I'll give you one example, and then I'm going to give you the one that I really want to focus on. But one has to do with that integration. One of the biggest programs I published on this quite a few times is a program. Am I allowed to use the name? Yep.
Yeah.
CapDots. It's called CapDots, which stands for CAPD, Central Auditory Processing Disorder Online Training System. And the reason online is that they changed from in-person training when this wonderful thing hit called COVID. Okay, and wonderful in two ways. Okay, wonderful meaning very ha ha ha, it wasn't so wonderful. But the other was that we learned a lot about how much we can do on like this, like what we're doing here, right, from COVID. And the thing is that they then started developing also games that children aren't going to do the activity, but they'll play a game. So that's a good way, and that's really very good. The other one is some research that I have just recently done. Am I allowed to say with you, Alex? Okay.
Please.
On something called acoustic neuromodulation, abbreviated acoustic A, neuro N, modulation M, ANM, or if you have auditory processing disorders, AMM. No, I'm joking. So it's acoustic neuromodulation, ANM. And it is based on research that has been done looking at sound. When we say sounds, I hope you would agree, sounds have a fancy word called frequencies. Okay? For example, a male voice, my voice, Alex's voice, any of the other men here, we have a voice or somewhere around 100, 150 hertz. You got that? Whereas a woman's voice is around 250 hertz. I hope you would say that's louder. Not louder, sorry. It's higher in pitch. Children's voices are somewhere around 400 hertz. And even infants, even a little higher. The thing is that the pitch, there has been research done showing the changes in the neural activity within the brain when certain frequencies of sound are being heard by the brain. And the thing is that you actually see changes. How many of you know that very often we look at the brain changes using the old Greek letters, the alpha, beta, gamma, and stuff like that? And there's specific frequencies that actually change these and obviously change them in a better way. So what if we developed a program of a listening therapy that used this scientific technology of the specific frequencies and had a person listening to them? Well, let's take a look at some of the research. We had a group of children, 16 children, all diagnosed with ASD. And one of the biggest things they had was, is this a good picture? Is that a good way to say it? Okay, right? Cancer. And the thing that we did was we had the parents, the teachers, and in some cases, even occupational therapists, other professionals working with these children, observe them and do what we call the questionnaires. How many of you are familiar with questionnaires, right? Okay, the inventory, okay, so the listening checklist. And the thing is that they identify what the children's problems were, or what they saw with the children. I can't say problem. What they saw with the children prior to doing the ANM therapy. Then they started doing the ANM listening. Okay, and the thing is, all 16 children completed the listening. Now we're going to go back as a comparison. Are you ready for this? The listening therapy, an excellent program, takes about maybe 40 weeks. Okay, but would you agree you might start seeing a change even after 20 weeks?
Oh, yeah.
So that's about halfway through the program, you start seeing a change. I'm not great at numbers, but there's 4 weeks in a month. 40 weeks is 10 months. God bless you, Nancy. And what you can see is a change usually within about 6 months. Sometimes even you start seeing some changes after 3 months. So I'll say this slowly again. 3 months, sometimes 6 months, typically after 10 months. You got that? Okay. We did the ANM I mean, if we had time, I'd say, let's take a guess and see how many weeks people could guess. Are you ready? 2 weeks. And there were significant changes, statistically significant changes in their listening, paying attention, their behavior, and being able to understand what you're saying. Parents saying this, or even the teachers saying this, there were tremendously significant improvements in auditory processing. Everyone again, after 2 weeks. Can you imagine that? Where did it come from? The research on the brain and, the frequencies and the sounds that we hear, and using that as a new way of doing listening therapy. So I'm hoping that that will be, more advanced in the sense of more people doing it, using it. Let's get some other research done on it and start getting people to do the A&M.
Yeah, I've really appreciated your willingness to lean in on this research with us, Dr. J. In the background, there's been other research going on for many, many years with colleagues until we brought this to Dr. Lucker to research together ourselves. So we're looking at the potential of introducing A&M, acoustic neuromodulation, through our providers. So this is a project that is ongoing in research, but we're exploring making available this year. So we're excited from what we've seen. It is frequency, it is not music. So it is not TLP, it's a very different experience. So, and some of you with us participated in that research. And I thank you for those that are here with us today that were also part of that in bringing clients and taking them through the A&M protocol. So we really appreciate your collaboration. So on that, I would like to move to our Q&A. Dr. J, we just have several dozen questions that we need to attempt to answer for this wonderful group of people. I think you've sparked so much of their curiosity. So we'll, tackle all that we can. If we haven't answered your question, please, let us know at ABT and we'll be sure to get that question answered for you after the webinar to the best of our ability. So we've got a question from Rachel, Dr. J. Would a child who doesn't know what's going on in their family possibly have an auditory processing disorder? So kind of, for example, the big family plans, celebration events, maybe they're a bit clueless about what's going on and, are not with it and present and understanding. And any perspective on that in an APD?
The answer is it's very possible, because one of the things, especially it's a child. So what do we do as parents? We very often tell the child and not really describe or discuss. That's important. Tell the child, oh, by the way, you're going to come home from school today. Try to get your homework done quickly. We're going to have a party. Your grandma and grandpa are coming down, and we're going to have the whole family getting together tonight for dinner. And the child hears this, okay? Okay, grandma and grandpa are coming. But when grandma and grandpa come, we'll make believe the adults decide to get together with grandma and grandpa, and the children, other than saying hello, they go, to play separately, and this child is lost. Wait a second. Because the child's interpretation, when they go to grandma or grandpa's house, is that grandma and grandpa play with them, and they're wondering, why aren't they coming to play with me? They're lost. And you may have a lot of problems with family. And I apologize to say this, but we'll make believe the mom told me what to do. And my response, this is internal, please, I apologize. The language I'm using, I know we're recording, is that goddamn mother, why can't she tell me the truth? Excuse me, I
Or
didn't want
father.
to use that language, but sorry, Alex. Yes.
Or father.
Or father, yes, yes. But being a father, I didn't want to use that.
Yeah. Me too, but we've, we're
Right.
often part of it, Dr. J.
Yes, yes.
Yeah, I that's super helpful. Dr. J, having done a lot of research with TLP, what do you find from your perspective, your view, are the most effective pre and post assessments for clients using the listening program?
Okay, well, I have to explain what I do is I do comprehensive auditory processing evaluations to look at every single area of auditory processing. Okay. And that's what I do. And then you do the therapy. One thing that I like to do is not to see you immediately after you complete the TLP, but give the body then some time. So typically it's about 2 months to six. Well, I say 6 weeks to 2 months. I just realized 6 weeks is a month and a half, right? So 6 weeks to 2 months afterwards, and then compare the pre-testing with the post-testing. It's formal standardized testing and see how the child is doing. From an overview, immediately, if you use the questionnaire, if you use the listening questionnaire, is to redo it, to have the person. The one thing I like, especially with children, is I try to get the parents to have the teachers as well do it, or have some, let's make believe that they are working with an occupational, no, that's bad because they're doing the therapy with them. Let's say they work with a speech language pathologist. Okay, then maybe have the speech language pathologist see what changes in speech, in language, in communication is being observed. And therefore you can compare A with B and see if there's a difference. If A shows a lot of, I'm just using numbers 1, 2, 3, 4, a lot of ones and twos, and all of a sudden you're now seeing a lot of fours and a couple of threes, I hope you agree. There's been a nice change.
Yeah, so I know you've liked the listening checklist. What's kind of the current state of the art of, say, things like the current version of the scan or the TAPS.
Oh, sure. Yeah, the scan 3 is the version. This is important, and this is where you need to make sure that when you're doing the scan 3, especially from a diagnostic point of view, it's being done through a calibrated presentation level. Okay. The reason is if I present to you, listen carefully, repeat these words, say the word chair, say the word house, say the word shoe. I was speaking very softly, right? Would you agree? You could fail because I'm too soft, but that's not the way people speak. And for example, I'm not putting you all down, but the average person, like psychologists, okay, if schools do it, anyone in the schools, speech language pathologists, just do it right off of their computer, or whatever. It's usually nowadays it's the computer, present it, but they don't know the volume level they're using. But it should be done at, I use 50 dB, should be done somewhere around 50, 55 dB. Okay. And you need special equipment to do that. Now, that's the best way. The second best way is using the same equipment initially and the same equipment post, and then see what changes there are. But you may not really be able to make a diagnosis that there's really a problem. But if you see a big change, then you know that there's been a big change.
Yeah, for sure. That's helpful. Lisa, and I'll field this question, Dr. J. Is TLP Spectrum the program that is recommended for auditory-based hypersensitivity, or is level 1 and Achieve also recommended depending on the needs of the client? The short answer is yes. Spectrum would be our go-to protocol, preferably with waves where we have combined air and bone conduction. If a client only has access to level 1, then that is the tool that we're going to use, but we may modify how we're using it. Level 1, both Spectrum and Achieve evolved from practitioners' modifications of level 1 protocols based on what they were seeing in their clients. So for clients that had more sensory needs, maybe more trauma background, more sensory sensitivities, they began extending time in the green zone in low frequency training of level 1. Well, after witnessing enough of that, we created a program that built that in. So we had expended time and we moved through the frequencies slower and in different progressions. Just as Achieve was brought in for more focus for communication and speech and language training in those frequency bands. So Spectrum would be our go-to, and then we can build on that and do more advanced training with level 1. We may then explore in time to bring a more rhythmic-based component into the training with whole body integration and rhythm combined with the listening. So there's a lot of flexibility because we know the structure of the listening programs are the same in terms of our ABC modular design, in terms of our full spectrum, our low frequency, mid, and high frequency training. And it's the combination, the frequency, intensity, and duration of how we use these where we modify and we customize. So I hope that answers the question. And we have time to finish with one question, Dr. J, and there are just so many. I think we will finish with, and I think this is an important one for us to consider. How would you explain, this is from Clarice, Dr. J, and it builds on something we spoke about earlier, but I think it's really important. How do you explain simply the problems of using earbuds with families?
Okay. So it goes back to what we were talking about before. And the real thing is the problem with using earbuds is that they cut off the child's mental, cognitive abilities and behavioral sensory abilities to listen for the sound. Okay. You're in a classroom. We're going to make it a small class because it's easy for me to use the number 20. Is that okay? Okay. That must be a private school then, right? You're in a
Yes.
small class of 20 kids. Okay. And the teacher is giving a lecture. Tell me if this is the way it goes in elementary. The teacher stands there behind a lectern and talks to the class like this. I hope you'd say no. They walk around, right? They move around, right? And especially with young children, it's funny. The younger the children are, that tends to very often be more movement with the teachers. The other thing is we ask questions and people, okay, so I'm sitting over here. The person all the way over there is answering the question. If I have the earbuds, would you agree? I do not need to learn. My brain does not need to learn how to focus on and locate and identify where the sound's coming from or who made the sound because it's coming right through my crutches. Is that a bad way to say it? But my assistant, the earbuds.
And
So it's great to listen to music when you're walking along, or if you want to just listen by yourself. That's not bad. Nothing wrong with that. But take those damn earbuds off when you have to listen to people talking, or when you're having a conversation.
And with your audiologist hat, you wear so many hats. Do we agree that prolonged use of headphones in ear, especially, first of all, can increase our susceptibility to hearing damage from overexposure to much decibel input coming in, and that the longer we have them in, the more we accommodate, and we will increase the volume over time and not realize that this increasing volume, the longer that we often wear them, is potentially causing further harm.
I totally agree, and it's unfortunate. And that's the generation we're in. We need to really build more listening skills with them. One thing that gets me very quickly, I'll say this, is our youngest son is not part of this. He's in the one generation below the one that's now. Okay. So he's kind of the end of the millennials, and the thing is that he even sees some of his friends who don't, excuse me for saying it, but his way of saying it is that I don't know why I even bother speaking with Alex. He doesn't give a damn what I say, meaning they don't pay attention. They're just not paying attention because it comes in here. I don't have to pay attention. It's already delivered to me. Yeah.
One quick one 2 or 3 sentences, what's your opinion of FM systems for APD?
Okay. My opinion of that is that when you break your leg, use the crutches. But then once you go through all the therapy, get rid of those crutches and start running. You understand what I'm saying? Use the FM system while you are doing the listening therapy and slowly reduce the FM until eventually take it away. It is a crutch.
Thank you. In closing, Dr. Lucker, is there anything we didn't touch on or any final words you'd like to share with our group today?
We touched on a lot, so I hope that it was good, and I hope it was, well explained, and everyone's learned it. If there are any specific questions that come up, and if it's okay with you, Alex, you can forward them to me. I'll be very happy to provide an answer. Okay, but thank you all for coming. It was great. Thank you.
Dr. J, so appreciate your expertise and the heart and the intention that you bring to your work. You're incredibly passionate about this, and we really appreciate all you're doing to contribute to the field at large. And I'm thrilled that when we stepped away from Howard University and became professor emeritus, that we continued education, because I have met with and spoken to so many of your students over the years, and they hold you in incredibly high esteem.
Thank you. Thank you.
Thank you for all your work, and thank you everyone for joining us. And watch out for an email soon with some follow-up information, and just make it a great day. And thanks for being with us.